Yes, Ishani, go ahead.
Chairman sirs, esteemed audience and friends, I'll be comparing lengthening over nails, LON, and lengthening with external fixation. Limb lengthening is needed in congenital, developmental, and post-traumatic, infective, and neoplastic sequelae. The LRS, Ilizarov, and hexapod fixators are routinely used for limb lengthening. Lengthening over a nail was described by Paley in 1997, after which it has been routinely used. But there's not much literature that compares these two techniques. We aim to compare LON with fixators. Our study consisted of 111 segments of LON compared to 115 segments with external fixation. The mean age of LON group was older at about 26 and of LEF was around adolescence. We use the Ilizarov fixator in 28 femora and 65 tibia, the LRS for only femurs and TSF saw the least use. 61 tibia had the standard tibia trauma nail, special straight nails were used in 39 femora and humerus nails in 4 femurs and 8 tibia as described by Gordon. LEF was done by the standard method. LON required special but affordable instruments like the straight nail, the rigid reamer, polar screws and accurate planning, which was done with the help of full length x-rays, full segment x-rays in AP and lateral and the magnification markers which help to choose the nail with the proper length and diameter. The access viability of the entry point was important. The LON procedure, external fixator pins inserted, reaming done, nail inserted up to the planned osteotomy site, osteotomy done, nail inserted further and locked only proximally, kept free distally to let sliding and lengthening, external fixator removed and nail locked distally after length is achieved. Note that the external fixation pins were posterior to the nail. Now, LON was indicated in non-infected cases, in roomy patent canals, accessible entry points and usually after skeletal maturity. Illustrating some cases. Now in this case, LON could not be done in the femur because the canal was narrow and sclerotic and hence LEF was chosen. In this case, proximal entry for the LON was not possible due to severe coxa valga and distal entry was not possible due to patella baja, so the LEF was done. LON was mostly done after skeletal maturity. In 4 pre-adolescent patients, we have used the humerus nail through a trochanteric entry as described by Gordon. We analyzed the outcomes based on the length gain, percentage lengthening, external fixation duration in days and index as days per centimeter. We calculated the level of difficulty score as given by Paley and noted complications. This was a retrospective level 3B study and the 2 groups were matched for the level of difficulty score. We found that mean length gain was similar in both methods. Percentage lengthening was significantly more in the LEF group. For the same amount of lengthening, external fixation duration and index was half in LON and this was statistically significant. The level of difficulty score was similar and the groups were comparable. Comparing the nuances of LON and LEF in cases. This 2-year-old child post-septic bone gap of 4 centimeters and external shortening of 6 centimeters had a fibular graft to fill the distal defect and proximal corticotomy with the Ilizarov was done. The defect filled well, the length was achieved within 6 months. This highlights the utility of the Ilizarov fixator in complex cases like bone gaps where no other fixators, especially at his young age, would have worked. For the 16-year-old girl with 3 cm shortening and valgus in the femur, the valgus was corrected acutely using rule 2 of deformity correction and lengthening was done gradually. The LON enabled early fixator removal in just 1.5 months. But in contrast, for the similar shortening and deformity, LEF took much longer to gradually correct and lengthen through the same site. In this femoral overriding malunion with 4.5 cm shortening leading to LON, he achieved target length in just 2.5 months with full knee flexion in 3 months post-fixator removal. In a case with similar discrepancy, where LON could not be done, he got LEF, but it took double the time and post the fixator removal, his knee range of motion was only 70 degrees. A case of double femoral and single tibial LEF done in the same patient with a large discrepancy. The severe tibial deformity as a sequela of compartment syndrome. The 5 cm length was achieved very fast with the LON in the undeformed femur and he was free from the fixator soon, but the tibial lengthening happened gradually along with the deformity correction. A case of double femoral and single tibial LEF done in the same patient with Ollier's disease dysplastic bone, large shortening, as well as large multiple deformities. The LEF was the only option in such cases. Over 15 months, he gained the lengthening and deformity correction amounting to 19 centimeters, and repeat lengthening was done again with LEF after 2 years. We noted the complications: deep IM infections, premature consolidation, axial deviation. While superficial pin tract infections are commonly known, deep IM infections were noted in LON, but LON prevented severe axial deviations. The other complications of LON like nail break and loss of fixation were treated by converting to LEF. The solution for the deep IM infection is remove the nail, re-debride, maintain or add external fixation, insert an ABC rod, add antibiotics as per culture. All the infections were resolved. One had a sequela of knee stiffness. When premature consolidation occurred, we solved it by extracting the nail partially, repeat the corticotomy, reinsert the nail and lock the nail distally. And the lengthenings continued. In one case, we needed to convert the LON to LEF, and in some cases, the patients refused a repeat corticotomy and the length fell short. The obstacle of knee stiffness, as in this patient, was solved by quadriceps plasty and arthrolysis. This was usually done 6 months to 1 year after the fixator removal. Coming to the discussion, literature review showed that the other studies mostly had single segments and far lesser numbers. Only in one study by Sun et al, it was more segments, but they were all cosmetic lengthenings and only in the tibia, so the level of difficulty was less. The strength of our study was the large numbers, the comparison, both used in the tibia as well as the femur, and the high complexity of the cases. The limitation that the group was not matched by age and etiology. Analyzing our large series, we found that LEF is versatile, can be used in all ages, causes, segments, deformities, and can correct complications of LON. But LON is convenient for the patient as compared to LEF and extremely cost effective, almost 50 times so as compared to advanced internal lengthening nails. LON efficiently corrects wide range of shortening and deformities, as in this case of a radiologist with fibrous dysplasia who had shortening of 12.5 centimeters. Double level deformity correction was done with the LON and he achieved target length as well. In conclusion, both LON and LEF are effective for lengthening and deformity correction, but lengthening over nails significantly reduces the external fixation time, helps with faster knee range of motion recovery, and is very convenient for the patient. But LEF has universal applications and can solve most complications of LOL. Paying homage to Dr. K.S. Masalawala's memory, I thank you for this opportunity.
Thank you, Ishani. Any questions?